Did you know that more people die every year because of missing medicines than from some of the world's most well-known diseases? Across continents, hospital shelves once filled with antibiotics, insulin, and chemotherapy drugs now stand hauntingly empty. Doctors are being forced to make impossible decisions: who gets treated and who must wait. Hello and welcome. Today we're exploring when medicine runs out, the hidden cost of global drug shortages. This episode uncovers one of the least visible but most devastating crises in modern healthcare, a world where medicine itself has become scarce. We'll dive into how this happened, why it's worsening, and what it reveals about the fragile foundations of our global health system. Before we can understand how medicine runs out, we must first ask, what exactly is a drug shortage? In public health, it refers to a situation where the supply of a medication cannot meet the demand for patient treatment. But in reality, it's far more than numbers or supply chains. A drug shortage is the moment when the promise of modern medicine fails. It doesn't only happen in war zones or poor nations. It happens in world-class hospitals where cancer drugs are rationed, antibiotics delayed, and insulin doses stretched thin. It happens when pharmacies post handwritten signs that read, "out of stock," and families walk away knowing that a cure exists, just not for them. According to the World Health Organization, over 80% of countries have reported shortages of essential medicines in the past 5 years. The affected drugs aren't rare or experimental. They are the ones that save lives daily: antibiotics, anesthetics, chemotherapy, painkillers, and heart medications. These are the foundations of health systems, the silent guardians of life, until they disappear. But shortages aren't just about scarcity, they are symptoms of a broken design. Over the past decades, global medicine manufacturing has become dangerously centralized. More than 2/3 of the world's active pharmaceutical ingredients, the chemical cores of drugs, come from only 2 countries, India and China. This has made production efficient, but fragile. A single factory fire, export ban, or border delay can send shockwaves through hospitals half a world away. The modern drug system was built on a dangerous assumption that the flow of medicine would never stop. But in a world shaped by pandemics, wars, and profit-driven competition, that assumption no longer holds. When medicine runs out, it doesn't simply reveal a shortage. It exposes the illusion of stability that public health has depended on for decades. When medicine runs out, the headlines stay quiet, but hospital corridors do not. Behind every missing vial lies a face, a story, and a slow unraveling of trust in the system meant to save lives. In one pediatric ward in Kenya, a mother holds her feverish child while a nurse apologizes. The antibiotic that could save her life hasn't arrived for 2 weeks. In the United States, oncologists have to delay chemotherapy for thousands of cancer patients because critical drugs like cisplatin are unavailable. In France, surgeons cancel operations when anesthesia runs out. The same pattern repeats in every corner of the world. Different contexts, same consequence. The human cost is measured not only in deaths, but in suffering prolonged. A person in pain without morphine. A diabetic without insulin. A patient waiting for heart medicine that's stuck at a border. Each shortage is a fracture in the moral promise of healthcare, that when you are sick, someone will be able to help you. For doctors and nurses, the crisis is unbearable. They are forced into triage ethics, deciding who gets the last dose, who must wait, and who will not survive the wait. In one study, over 70% of healthcare workers in low-resource settings said drug shortages were their biggest obstacle to care. The shortage doesn't just steal medicine, it steals their humanity, and the damage doesn't end inside hospitals. When antibiotics are scarce, infections spread faster. When vaccines are delayed, outbreaks resurface. When mental health drugs are missing, suicides rise. These shortages ripple across societies, weakening economies, disrupting families, and deepening inequality. This is not a logistics problem. It's a justice problem, because medicine doesn't simply treat disease, it defines dignity. And when it disappears, the message is clear. Some lives are valued less than others. The silence surrounding this crisis makes it even deadlier. There are no front-page headlines for the absence of a cure, no footage for what never arrived. But in that silence, millions of preventable deaths are written every year, quietly, invisibly, and avoidably. The world has learned to count the cost of disease. It's time we learn to count the cost of neglect. The global medicine shortage did not appear overnight. It was engineered slowly, through decades of choices that prioritized efficiency over endurance, profit over protection. What was once a network of healing has become a fragile web stretched to its breaking point. To understand how it broke, we must start with the supply chain. Nearly 70% of the world's active pharmaceutical ingredients, the core chemicals that make up modern medicine, come from just two countries, India and China. This concentration has made drugs cheaper to produce, but catastrophically dependent on a few factories and a few shipping routes. When a single plant closes due to contamination or political tension, the effect is global. A shortage in one city in India can mean an empty pharmacy shelf in Canada, Ghana, or Vietnam. The logic that created this dependency is the same logic that drives modern capitalism: cost reduction. Generic medicines, which form the backbone of public health, are sold so cheaply that manufacturers often abandon production altogether. Why produce a $2 antibiotic when a $200 lifestyle drug can make 10 times the profit? Governments, pressured to cut healthcare costs, award contracts to the lowest bidder, and in doing so, eliminate redundancy. Only a handful of companies remain to make each essential drug, and when one falters, the entire system follows. This efficiency-first model gave birth to what economists call just-in-time manufacturing, a process that eliminates excess storage to save money. For cars or electronics, this system works. For medicine, it is deadly. Hospitals now operate with minimal reserves, relying on shipments to arrive precisely when needed. But pandemics, wars, or trade restrictions don't follow schedules. One delay, one storm, one broken link, and the pipeline collapses. Regulation adds another layer of fragility. Safety inspections are essential, but when violations halt production, the replacement process can take months or even years. Governments are often hesitant to intervene, bound by market laws and corporate influence. The result is paralysis disguised as policy. At the heart of this failure lies a moral contradiction. Medicine has been treated as a market product rather than a public good. Patents, trade agreements, and shareholder interests now shape the boundaries of who lives and who dies. Innovation is rewarded. Reliability is ignored. The system doesn't fail because it's broken. It fails because it works exactly as designed. When the pursuit of efficiency erases redundancy, fragility becomes inevitable. And when health is left to the invisible hand of the market, the invisible casualties multiply. The drug shortage crisis is not an accident. It is the logical outcome of a world that measures value in profit margins instead of human lives. From the outside, it is easy to believe that drug shortages belong to poor countries, that they are symptoms of poverty, corruption, or weak infrastructure. But step into a hospital in Paris, Toronto, or Tokyo, and you'll find the same crisis playing out in silence. The difference is not in the problem, but in the privilege of delay. In the global north, the shortages reveal themselves through inconvenience. A delayed surgery, a postponed chemotherapy, a pharmacist explaining that a prescription will take a few more days. Patients grumble, but few die immediately. Behind the scenes, administrators scramble, diverting scarce supplies from one hospital to another, negotiating with manufacturers, substituting weaker alternatives. Every solution is temporary, every victory borrowed. In the global south, the same shortage means something else entirely. There are no backup plans, no substitute drugs, no alternative treatments. A delayed shipment becomes a death sentence. A power outage at a single production plant can deprive entire regions of antibiotics or vaccines. Clinics in Haiti, Kenya, or Bangladesh ration medicine by necessity, not by policy, cutting pills in half, diluting doses, stretching supply beyond safety. The gap between these two worlds is not just measured in access, but in options. In London or New York, private clinics and wealth can buffer scarcity. In Nairobi or Kabul, there is only waiting. And yet both are connected. Both rely on the same global supply chain, the same fragile web of factories, freighters, and patents. The pandemic made this painfully clear. Rich nations hoarded supplies, while poorer nations begged for scraps. But when the chain broke, the shockwaves came for everyone. Even within single countries, inequality mirrors this divide. Urban hospitals receive what little stock remains, while rural ones are left to improvise. Pharmacies in wealthy neighborhoods restock first. Those who can pay find a way. Those who can't simply fade from the data. This is what global inequality looks like when it's written in medicine, a two-tiered system that promises universality but delivers exclusion. The rich get delays, the poor get death. Yet the crisis binds us all. Because when medicine becomes a privilege anywhere, it becomes unstable everywhere. In a world that shares its supply chains but not its compassion, no one is truly immune to collapse. The virus of inequality infects even those who believe they are safe. As the shortages deepened and hospitals across continents reached their breaking point, the world began to realize that this crisis was not temporary. It was structural. And if the structure was the problem, then the only solution was to rebuild it. The first step was recognition. The World Health Organization has long maintained its essential medicines list, a catalog of drugs that every country must guarantee for its people. But a list means nothing without access. After COVID-19 exposed the fragility of supply chains, a wave of new initiatives emerged to reinforce the world's medical backbone. In 2021, the European Union launched the Health Emergency Preparedness and Response Authority, HERA, a permanent system designed to predict shortages, monitor supply chains, and coordinate emergency stockpiles across Europe. In the United States, the Strategic National Stockpile was expanded to include not just vaccines, but painkillers, anesthetics, and antibiotics. An acknowledgement that the next health emergency might not come from a virus, but from an empty warehouse. Meanwhile, the Global South began taking matters into its own hands. India, already known as the pharmacy of the world, invested in expanding domestic production of raw ingredients and generic medicines. South Africa and Brazil developed regional manufacturing hubs to reduce dependency on imports. Vietnam, Indonesia, and Nigeria began building local pharmaceutical industries from the ground up. Each of these nations understands a fundamental truth. Health sovereignty begins with the ability to make your own medicine. Technology has also entered the fight. Artificial intelligence is being used to track global shortages and predict where they'll strike next. Blockchain systems now trace medicine from factory to pharmacy, preventing fraud and ensuring accountability. Researchers are even experimenting with 3D printing of drugs, allowing hospitals to produce small quantities of essential medicines on site during emergencies. These are not futuristic fantasies. They are signs of a healthcare system trying to evolve. But technology alone cannot fix what ethics has broken. The fundamental problem remains. Medicine has been treated as a commodity, not a right. Until that changes, every solution will be temporary. The conversation in global health circles has begun to shift toward a new idea, the idea of medicine as a global public good. This means prioritizing access over ownership, transparency over trade secrecy, and cooperation over competition. It means acknowledging that life-saving drugs should not belong to markets, but to humanity. Some progress is happening. Partnerships between governments and NGOs are investing in open-source pharmaceutical manufacturing, where drug formulas are shared rather than sold. Donor nations are reevaluating patent protections for essential drugs. And public health experts are urging a global treaty, similar to climate accords, to ensure equitable medicine production and distribution during future crises. Still, progress moves slower than the suffering. The will to reform often fades as soon as the headlines do. The challenge, as always, is sustaining urgency in a world that forgets fast. The global drug shortage has made one thing painfully clear: no system built on scarcity can protect life. And yet, somewhere between the laboratories, policies, and production lines, humanity still has a choice. The tools exist. The knowledge exists. What's missing is the commitment to use them. The fight for medicine is no longer about logistics. It's about justice. The story of global drug shortages is not about the absence of medicine. It's about the absence of foresight, fairness, and moral responsibility. It forces humanity to confront an uncomfortable truth. Our health systems were never designed to be equitable, only efficient. And efficiency, when pushed too far, collapses under its own weight. 3 lessons rise from the ruins of this crisis. First, medicine without access is not medicine at all. Scientific progress means nothing if it cannot reach those who need it. A vaccine that sits in storage, a drug trapped by patents, a shipment delayed by profit negotiations, these are failures not of science, but of ethics. True innovation does not end in the laboratory. It ends when the cure reaches the patient. Second, resilience must replace efficiency. For decades, global health has been built on the illusion of constant flow, a just-in-time model that left no room for disruption. But pandemics, wars, and climate disasters are no longer exceptions. They are constants. A resilient system must plan for uncertainty, invest in redundancy, and protect supply chains not for profit, but for survival. Third, health is not an isolated sector. It is the foundation of every society. Every medicine shortage weakens economies, paralyzes education, and deepens inequality. When a hospital runs out of drugs, factories lose workers, families lose income, and nations lose trust. Health is not just a cost to manage, it is the infrastructure of civilization itself. The shortage crisis has exposed something larger than broken logistics. It has exposed the moral architecture of our world. We have built a system that measures the value of medicine by its price, not its purpose. We have allowed competition to masquerade as progress, and scarcity to masquerade as inevitability. Some progress is happening. Partnerships between governments and NGOs are investing in open-source pharmaceutical manufacturing, where drug formulas are shared rather than sold. Donor nations are reevaluating patent protections for essential drugs. And public health experts are urging a global treaty, similar to climate accords, to ensure equitable medicine production and distribution during future crises. Still, progress moves slower than the suffering. The will to reform often fades as soon as the headlines do. The challenge, as always, is sustaining urgency in a world that forgets fast. The global drug shortage has made one thing painfully clear: no system built on scarcity can protect life. And yet, somewhere between the laboratories, policies, and production lines, humanity still has a choice. The tools exist. The knowledge exists. What's missing is the commitment to use them. The fight for medicine is no longer about logistics, it's about justice. The story of global drug shortages is not about the absence of medicine. It's about the absence of foresight, fairness, and moral responsibility. It forces humanity to confront an uncomfortable truth. Our health systems were never designed to be equitable, only efficient. And efficiency, when pushed too far, collapses under its own weight. 3 lessons rise from the ruins of this crisis. First, medicine without access is not medicine at all. Scientific progress means nothing if it cannot reach those who need it. A vaccine that sits in storage, a drug trapped by patents, a shipment delayed by profit negotiations. These are failures not of science, but of ethics. True innovation does not end in the laboratory. It ends when the cure reaches the patient. Second, resilience must replace efficiency. For decades, global health has been built on the illusion of constant flow, a just-in-time model that left no room for disruption. But pandemics, wars, and climate disasters are no longer exceptions. They are constants. A resilient system must plan for uncertainty, invest in redundancy, and protect supply chains not for profit, but for survival. Third, health is not an isolated sector. It is the foundation of every society. Every medicine shortage weakens economies, paralyzes education, and deepens inequality. When a hospital runs out of drugs, factories lose workers, families lose income, and nations lose trust. Health is not just a cost to manage, it is the infrastructure of civilization itself. The shortage crisis has exposed something larger than broken logistics. It has exposed the moral architecture of our world. We have built a system that measures the value of medicine by its price, not its purpose. We have allowed competition to masquerade as progress and scarcity to masquerade as inevitability. But there is nothing inevitable about this. The same intelligence that mapped the human genome, that created vaccines in record time, that conquered diseases once thought unbeatable, that same ingenuity can rebuild a system where no one dies for lack of medicine. The question is, not can we, it is will we. Because medicine is not just chemistry, it is covenant, a promise between humanity and itself. And right now, that promise is being broken. When medicine runs out, the silence is louder than any alarm. There are no explosions, no collapsing buildings, no headlines. Just waiting. Patients waiting for a cure that never arrives. Families waiting for news that never comes. Doctors waiting for shipments that won't make it in time. It's a slow, invisible disaster, but one that is rewriting the very meaning of global health. When medicine runs out, the hidden cost of global drug shortages is not just a story about missing drugs, it is a mirror held up to our civilization. It shows how much we depend on systems we barely understand, and how fragile those systems truly are. This is not a failure of technology or science. It's a failure of humanity's priorities. Because when profit decides who gets access to life, medicine loses its soul. The next great global health crisis might not come from a virus or a new disease. It might come from something far simpler. The silence of empty shelves. No sirens, no warnings. Just absence. A slow erosion of trust, a quiet betrayal of the belief that help is always on the way. But it doesn't have to end that way. Around the world, movements for medical justice are growing. Scientists sharing open-source formulas, nations building their own manufacturing capacities, and communities demanding transparency from the pharmaceutical industry. These efforts prove that the story of medicine can still be rewritten. Real change won't come from charity, it won't come from panic, it will come from awareness, from action, from the refusal to accept that scarcity is natural. Because medicine, like clean water or oxygen, was never meant to be a privilege. It was meant to be a right. If this story opened your eyes, don't let it end here. Share this video, start the conversation, and subscribe for more investigations into the hidden systems shaping global health. Awareness is the first dose. Change is the cure. And remember, when medicine runs out, humanity runs out of excuses.